Hello, welcome to a discussion on congenital heart disease, cyanotic congenital heart disease, anatomy and physiology. This is mainly focused on for medical residents in pediatric residency. There are a few things we will discuss in this brief lecture, which will be what is cyanosis, facts and fallacies of a pulse oximetry. Then we will discuss a few of the most common cyanotic heart disease that includes tetralogy of Fallot, transposition of great arteries, truncus arteriosus, anomalous pulmonary venous drainage, and single ventricles. We'll start with the universal screening for cyanotic heart disease in babies. This is a modified version from 2018. The guideline says first, do a pulse ox on the right hand and 1 foot around 24 hours of age. Passes pulse ox of 95% or more in the right hand and foot and a difference of 3% or less between the two. Do not repeat pulse ox and continue normal newborn care in this situation. They fail if the pulse ox is 89% or less in either right hand or foot. Do not repeat the screen and refer to NICU or cardiology immediately. In between is the criteria for retesting. So if the pulse ox is between 90 to 94% in either the right hand or foot, or the difference of 4% or more between right hand and foot, then you repeat the pulse oximetry measurement in 1 hour. Second measurement is also like first measurement, pulse ox on the right hand and 1 foot, 1 hour after first measurement. And if they fail or pass, and you follow the algorithm from the beginning. Now, coming to a very basic question, what is cyanosis? So, cyanosis is a very old term and has been used to describe a blue person. It's a visual diagnosis and was extremely relevant before modern medicine. Once we have modern medicine, we are obligated to define cyanosis by measurement. Also, cyanosis was mostly defined in fair skin color. However, in patients with brown or a black skin color, it can be hard to define cyanosis. There can be central or peripheral cyanosis. Central cyanosis is the one we're talking about, and that is usually the cause of major mortality and morbidity. So, to define central cyanosis, you have to use some kind of measurement. The two important things that you can use to define cyanosis is a pulse oximetry and an arterial blood gas. If the pulse oximetry is less than normal, or if the blood gas results show a low PO2, you can tell a patient is cyanotic. Now, before deep diving into cyanosis due to heart disease, we have to have a very basic concept of what it means to be cyanotic. Does blue mean that the patient is dying? That is not necessarily true, and this is how I'll show you how the body is really dependent on oxygen. So the key issue is oxygen delivered to tissue. If the oxygen to the delivery to the tissue is suboptimal, the patient will not do good. If the oxygen delivery to the tissue is good, then the patient will do fine. Now, the oxygen delivery to the tissue depends not only on oxygen in that we detect in the pulse ox, but the following. First is hemoglobin affinity for oxygen. So if a patient has fetal hemoglobin, they release the oxygen faster than adult hemoglobin. Distribution of blood to each capillary bed. You can think of diving reflex when your blood flow is distributed from the skin and kidneys into your heart and brain in early part of shock, in hypoxic ischemic encephalopathy and things like that. Cardiac output definitely determines how oxygen is delivered to the tissue. And finally, systemic oxygen content. Now, the systemic oxygen content is dependent on hemoglobin concentration. A patient with anemia will have low oxygen delivery to tissue because of poor systemic oxygen content. Oxygen saturation, this is where we define cyanosis and partial pressure of oxygen, which we can pick up by a blood gas. Now, oxygen saturation can be due to a pulmonary venous desaturation or lung disease, or shunting or mixing within the heart, or cyanotic heart disease. Now, before the next step, we need to pause for a second and think about the fallacy of pulse oximetry. Now, pulse oximetry since the 1970s is used very frequently, almost every day, in all clinical settings. Now, you have to remember that pulse oximetry is not a blood gas. There's a big difference. The difference is it works by a Beer's principle or Beer's law, which emits a light that passes through the skin and the tissue and gets absorbed on the other end of the probe. During its journey, it gets absorbed, and the light traveling is analyzed on the receiving end, and then it can determine how much oxygen is bound to the hemoglobin. Now, that can be a venous hemoglobin blood, or it can be an arterial hemoglobin blood. The way it differentiates is by pulsation. The amplitude of the blood flow is essential for the signal traveling to detect the change of oxygen, or the oxygen concentration in the capillary bed versus the venous capillary bed. So a person who is in shock, who has low amplitude, will give you a falsely low number in the pulse ox, although the oxygen bound to the hemoglobin may be normal. At the same time, if the pulse ox is not properly placed, it will not pick up the pulsation, and it will pick up a venous pulsation or venous blood saturation, and then your numbers will be falsely low. So pulsatility in the measurement is extremely important to have an accurate measurement. We'll start with our first cyanotic heart disease, the tetralogy of Fallot. Very common. This is a diagram from the Mullen's book. He had made these diagrams in his early career to understand heart diseases, and this has become a staple diagram for all cardiologists, especially pediatric cardiologists across the world. The blood from the head and neck comes through the SVC. Blood from the lower part of the body comes to the IVC, mixes into the right atrium. It goes to the right ventricle. From the right ventricle, it gets stuck or hit by this narrowing under the pulmonary valve, as well as a small pulmonary valve. So a fair amount of blood goes from the right ventricle to the left ventricle, causing the blueness. But since the left ventricle is also on high pressure, there is usually a bidirectional shunting. In cases of TED spells, there are no blood cells or no RBCs can go through this area, so everything goes from right to left through this ventricle. and the patient is severely blue. Typically at birth, these patients are not cyanotic. They become cyanotic over time. They do have TET spells. Typically, if you have TET spells, that's an indication of surgery. Now, these patients can be repaired in different times. Some centers will repair them at birth. Some will put a shunt in them and then repair them later on. Some physicians will give beta blockers with the hope of relaxing the interfundibulum and promoting more blood into the pulmonary artery, but there is a questionable benefit of that. Going to the next cyanotic heart disease. Next, we're going to look at a few types of single ventricles. The first one is a hypoplastic left heart. You have a right atrium, a nice right ventricle that gives up the pulmonary artery, a left atrium, but there is no left ventricle. The ascending aorta is extremely small, so the rest of the aorta is supplied by the PDA. These patients are typically not cyanotic, present in the first few days of life in shock, but pink. This one is an example of pulmonary atresia with intact ventricular septum and a small right ventricle. They usually present as cyanotic heart disease. You can see right atrium is good size, left atrium is good size, left ventricle is good size. There is normal connection, but there is no prograde flow. So these patients will typically need a perforation of this valve in the cardiac cath lab, or a shunt or a PDA stent to provide pulmonary blood flow. This is a double inlet left ventricle. As you can see, right atrium has a valve that goes into this smooth walled large ventricle. Although this is in the right side, this is the smooth wall in the diagram suggests it's a left ventricle. This ventricle has another inlet from the left atrium, so it's double inlet left ventricle. There's a small right ventricle. The left ventricle gives rise to the pulmonary arteries, like a transposition of great arteries. The right ventricle gives rise to the aorta. So this is double in the left ventricle with transposition of great arteries. Similarly, this patient also has a transposition of great arteries. However, you see the right ventricle, the right-sided left ventricle gets only one AV valve. So this is not a double inlet left ventricle, but this is transposition of great arteries and an hypoplastic right ventricle. I'll give you some numbers to give an idea of what a saturation is for what type of heart disease. So repaired congenital heart disease, if you have a patient in the ER who has a history of a repaired congenital heart disease, they should have a normal saturation for age. And all acyanotic heart diseases that are congenital should have normal saturation. So like ASDs, VSDs, and PD, if they are desaturated, we have to look for causes. The pathologies where you see a saturation between 90 to 100% are Fontane's of all variety and partial anomalous pulmonary veins. The rest of the cyanotic heart diseases are typically has a saturation between 75 to 90% or 95%, like tetralogy of Fallot, transposition of great arteries, hypoplastic left heart stage 1 and stage 2, total anomalous pulmonary venous return, single ventricle PDA stents, and single ventricle in the Glenn stage. Thank you. I hope this will be a very helpful short video. Please feel free to email me or text me for any questions, and you have a good rest of the day. In this video, you'll find more links to my other videos. Feel free to subscribe and like.